Lisa, Lisa and Shannon, take it away.
So I'm just going to start very briefly and hand it over to the real speaker. But yeah, just a couple minutes to tell everybody a little bit about TREC, because some of the information in this presentation is related to TREC, and a lot of you will know about TREC. It's the administrative center is here. It's Terry's the director and I'm the network manager, but there's a lot of new things that have happened over the last year that we want to share with you. And then there's a lot of other information that as KT, a lot of experience in KT Lisa and Shannon have that they'll share with you. So we just wanted to acknowledge, so as Terry said, Lisa and Shannon are part of the co-directors and form the executive team of TREC, but we also have two other co-directors, Dr. Mona Javor and David Johnson, who are here with us today as well. So we wanted to acknowledge this is a team effort, and some of the information that we're showing you today related to TREC, you know, it's been done through a very large team. We're actually, as Terry said, we had a board meeting today, an all-day board meeting, and because we're a national network, we don't get together very often, or we don't get to be in one place very often. So we're very happy that we're all here together in the executive team as well as members of the board and steering committee, and who collectively give their energy and enthusiasm and expertise to making a successful network in mobilizing pediatric emergency care. I'm going to just move over here today. So just for those of you that don't know what TREC is, it was born out of the knowing that the majority of kids in Canada, when they need emergency care, they don't seek treatment. The majority of them don't get that first point of care in a children's hospital. So 85% of the children go to a general emergency department. So these are emergency departments that are not connected to a pediatric center. And we know that 40% of the treatments that they have are based on, well, they're not based on treatments where clear evidence exists, and in some cases, 1 out of 5, they may get a treatment which is of no benefit or even harmful. So TREC was born to try and improve those statistics and support our colleagues in these general emergency departments to get easy access to the latest knowledge. We started in 2011, and this is what we look like today. We are in 9 provinces and 1 territory. We have 12 pediatric centers involved in TREC, and they're connected with anywhere between 2 and 5 TREC sites. So TREC sites meaning a general emergency department. There's 37 formally connected with TREC and have been with us pretty much from the outset in 2011. But we really want to expand that and be much more far-reaching. And our resources are on our website. It's open access, and there's more than 37 sites now. Looking at our resources and using them. We also want to acknowledge we've got 24 partner organizations and 92 active community members that include parents and healthcare professionals and researchers who help to build this network and the processes involved in it and the tools that we've created, and 31 researchers who help to vet the resources and to create tools where none exist. And Lisa and Shannon will go into a little bit more detail about that. This slide represents how closely we are connected to Pediatric Emergency Canada, so that's PERC. That is a research network here in Canada that has multi-center random control trials in pediatric emergency care. So they're creating that new knowledge of which TREC helps to ensure the knowledge is used within the wider community, so outside of those children's hospitals. And through TREC, we can go back to PERC and help to identify knowledge gaps. And so, there's a real loop between the two networks, so between creating knowledge, disseminating it, mobilizing it, and identifying gaps. So we are coming to the end of our first round of first cycle of funding was 4 years. And over those 4 years, this was our knowledge mobilization strategy. So in order to, our ultimate vision is that no matter where a child goes in this country to get emergency care, that they, get the highest standard of care possible. So it started with a needs assessment, so finding out what the knowledge preferences and needs were for the healthcare professionals working in these general emergency departments and the parents, the families that go there. and assembling the current evidence based on the conditions that were identified that they wanted more information on. And then lastly, developing and sharing these tools to these centers. So that's been our focus for the last 4 years. And now I'm going to hand it over to Shannon, and between Shannon and Lisa, they'll give much more detail about that and some other work that they've been doing.
Thanks a lot, Lisa. It's really great to be back in Manitoba. It's so nice to see so many friendly faces. I have so many connections with many people in the audience from working at Winnipeg Children's Hospital, and Lisa Nisley and myself actually were in the same nursing class, and I won't say what year that was, but it's really great to be back. And normally I don't speak with some notes, but I'm going to do that because avoid room 508 at the Inn at the Forks. You don't get any sleep in that room, as Liza will tell you. She gave up that room, I've learned, and I got it. So the benefit of arriving early. Anyway, so as Lisa mentioned, we started off Trek by doing a needs assessment, and that really was the foundation for the work that Lisa Hartling and myself are going to talk about. And what that actually involved is that we did active data collection in 32 emergency room departments from coast to coast. We developed an iPad survey and had our coordinators out in the sites meeting with healthcare professionals and asking them about their information needs and preferences. This data was automatically all uploaded through encrypted Wi-Fi, so we were able to keep track of our data collection daily. In addition to collecting data from healthcare professionals, we also were very interested in the information needs and preferences of families that brought their child for care in the general emergency room department. So in addition to having this quantitative aspect, we also supplemented it with qualitative work to add richer detail, so this was purposeful. And we did some observation work in some emergency room departments as well as focus groups with healthcare professionals. And this is just, rather than having numeric slides with all of the key details. So what we actually learned, we learned many things, a wealth of information in terms of our participants, and really foundational in terms of that. So the key point that is really relevant for this presentation is are our findings from our healthcare professionals. And one of the key findings we repeatedly go back to is a question that we asked healthcare consumers or families when they brought their child in for care. Did they look for information prior to coming to the emergency room department? 39% of family members reported that they did. And the most important or most frequently identified source was that they looked on the internet for information prior to coming to the emergency room. So that's been very foundational for us in terms of as we move forward and develop interactive tools for families, keeping that in mind. So when we looked and asked families how they normally search for information and who they trusted to get information from, they really wanted information from trusted professionals, as well as they also currently looked for information on the internet. So again, just keeping that in mind. We also asked parents the reasons that they brought their child in for care. So the most commonly identified reason from a parent's perspective based upon symptoms was 17% of family members brought their child in for care because they had a fever. Also vomiting and stomach pain, 10% of families also identified that reason. Accidents and difficulty breathing. Now I'm sharing this with you because this has been really key as we make decisions about what products we want to develop for family members. So one of the big pushes as we have developed and analyzed our data is that we want to present information in ways that is engaging and does not present information in very boring academic ways that don't engage. So we developed these tools like infographics to share results back. one of the key findings that has really guided a lot of our work in TREC with healthcare professionals is also identifying priority conditions. And Lisa Hartling will talk more about this. But we identified 14 priority conditions that healthcare professionals told us they wanted more information on. And that really has guided our online repository. So now I'm going to tag Lisa.
Good afternoon. I'm Lisa Hartling, as I was introduced, and pleasure to be here. Really excited to be talking about our work. Like Shannon said and Lisa said, it's involved a huge number of people to deliver what we have already. So Shannon's work in needs assessment was just foundational to set the direction for what we were going to do next. And we had to really carefully consider how do we do the next steps. So we had the information from the needs assessment, but mobilizing knowledge is a huge, massive effort. And so some of the key steps we worked through was first of all, we had to assemble the current evidence, and then develop strategies and tools for dissemination. As has been touched on already, we had two key target audiences for TREC. One was the frontline healthcare providers in the general emergency departments, and the other was the parents and families of children seeking care. And we really, really wanted to address both of these audiences. And yet knowledge translation science tells us that our approach to these different audiences is going to be very different. And so we really made an intentional decision at the outset after the needs assessment to say, we need to start in a focused way, and we need to build there, make sure we're doing that well, and then expand to other audiences. And so we first targeted the frontline healthcare providers. So I'm going to talk a bit about how we assembled knowledge and the tools we developed for them. And then we'll get into some of the work that we're now moving into for the parent audience. We also knew that this was going to be a huge effort in terms of the number of conditions that were identified, the extent of evidence out there, and then the resource constraints, limitations we were working within. And so we really wanted to capitalize on existing evidence. We couldn't go out, my day job is doing systematic reviews, but I couldn't do a systematic review on all the questions and topics that were identified in our needs assessment, nor should we, because there was already a lot of good information out there. And so we wanted to find that and capitalize on that. And then we really wanted to respond to the healthcare providers' requests. And so this is where the needs assessment really drove how we move forward. So in part, what they also expressed in the needs assessment is they wanted varying levels of information and amount of detail. They wanted instant access to information. We identified the priority conditions. And then we set out in a very integrated approach. Because again, knowledge translation science tells us that it's not just about pushing out information. We need to know and have that iterative approach in terms of, is this the type of information you want? Is this the format that's going to be helpful for you? And so we really set out to do that, to create that model. In terms of assembling the evidence, and I remember the 4 co-directors sitting around a table, I think it was in this room. I was like, what are we going to do? We have the results of the needs assessment. How are we going to respond to these needs? And so we came up with this idea of a knowledge pyramid. Again, because everybody seemed to want everything. How are we going to meet everybody's needs? So this concept of knowledge pyramids, along the side here it says a hierarchy of knowledge, but I don't think it's actually a hierarchy of knowledge, I think it's a hierarchy of synthesis. So at the bottom of the knowledge pyramid are your primary studies in terms of randomized controlled trials, other comparative studies. Oops. Oh.
No, it's not when you touch the screen.
Diagnostic, prognostic studies. And then synthesized evidence in the form of systematic reviews, meta-analyses. There's even a layer in there of synthesis of syntheses. We've moved into doing overviews of reviews. And then up above that, there's clinical practice guidelines, pathways, decision rules that build on these layers. And finally, at the top, our bottom line recommendations for practice. And so what we did, for each priority topic that we identified in the needs assessment, we had 3 key players. So a research librarian who was based at my center in Alberta, a knowledge broker who was based here in Manitoba, And for each priority topic, we identified a clinical or content expert. For the first few, we used our closed circle of the track co-directors, and then we expanded this and looked for pediatric emergency specialists from our connections through PERC, who were known to be experts in the priority topics of interest. And so our research librarian would do searching, looking for the resources in terms of all those levels of the knowledge pyramid, deliver those to the clinical content experts. So is this the type of material you're looking for? And there was a bit of iterative back and forth there in terms of identifying resources. We didn't want to put every single last nugget of information we could find in those knowledge pyramids. And so the clinical content expert would also vet those resources in terms of what are the key papers, what are the key systematic reviews, and again, driven by the clinical questions and the priority topics that our stakeholder group had identified. The knowledge broker and the clinical content expert also started to develop the tool at the top of the pyramid, the clinical bottom line recommendation. They've had various names. And so together that team would populate the knowledge pyramid. Those resources that would then go to a steering committee made up of members in pediatric emergency medicine across the country. Once the resources were approved, they would go on to our programmer who developed a system to get them onto trek.ca. Also a system in which that it was easy to not only upload but to update content as new evidence and tools emerged. And so once we had done the first few pyramids, we wanted to get it out to our Trek members. Again, this was the iterative approach to say, are we getting this right? And so we pilot tested the first 3 knowledge pyramids for appearance, usability, and content among 35 of our stakeholder groups, 35 Trek members. And this is some of the feedback that they gave us. So 100% like the alphabetical listing of conditions. And so that's just how they appeared on the trek.ca site. And I'll show you a screenshot of that in a minute. 88% like the listing of resource type by level. So that was the knowledge pyramid approach. 83% felt the intent of the pyramids was clear. 91% said they would use the resources in their ED. Some comments, some said, I just want to get the recommendations for care. And so again, that really drove what we were providing. Another comment, I just want the most current best practice guidelines at our fingertips. And 80% indicated that the key studies should be included. So there we're hearing a number of messages. They want those key studies, they want what we put in the bottom of the pyramid, but many also just wanted to access that top of the pyramid. Tell me what to do. And so this is a screenshot of the trek.ca site. These are all the conditions that we have addressed to date, so for which we have resources on the trek.ca site. So they're listed alphabetically. And if we, they're under our resource page on the website. So if we click onto, I'm choosing gastroenteritis because that's what I know somewhat well. And so our pyramid actually goes across the top, again, based on user feedback in terms of how they wanted this to appear. And we see the resource type, bottom line recommendations. There's two documents in that category. Clinical pathways or guidelines, there's 2 documents in that category. Overviews or summaries of systematic reviews, and then key studies. And so we're on the bottom line recommendations page. We have them in both English and translated into French. And then the user can download those. So those come up first, and then if people want to dig deeper and go into more information and seek out more information, they're able to do that. So this is what our bottom line recommendation looks like for gastroenteritis. They all look similar, and they are a 2-page, so we can print them off as a front and back 1-page handout. And they're very short, as you can see, very specific about, here's what you want to do if you're treating a child with gastroenteritis. And that's just an image of the French translation. So these numbers change all the time. I had to ask these if these were actually up to date because we continue to grow. So we have about 23 bottom line recommendations, 52 clinical pathways or guidelines on our site, 34 overviews or summaries of systematic reviews, 131 case studies, and then some other learning tools that I'll talk about in a minute. Currently, there are approximately 200 downloads each month for just the bottom line recommendations. So we know people are using them, which is good. So again, the knowledge pyramids sit in what's called an evidence repository, which is listed in the resource page. And then there's a number of other tools in here. One is called the Cochrane Pediatric Emergency Medicine Reviews. So Terry mentioned that I'm also involved with the Cochrane Child Health Field. As part of that remit, we have a database of all child-relevant Cochrane systematic reviews. And what we did for TREC is identified out of there all the PEDS emergency-related systematic reviews. We then worked with the publisher to get an agreement to post the plain language summaries. And so within the TREC site, we now have anything PEDS emerge related on the TREC site with the plain language summaries. We developed some podcasts, and we have some podcasts that were developed for other purposes. So those are on there as well as some other learning tools. So for gastroenteritis, for example, we have Dr. Stephen Friedman, who's an expert in this area, doing what we call the TREC talk, and his slides and audio recording of a talk he did. And then we have another section for patients and families that we'll get to. So a large part of our dissemination strategy was by word of mouth. Meetings, we started to gather networks. So each pediatric site, as Lisa mentioned, is affiliated with 3 general emergency departments, so a lot of word of mouth, sending out newsletters, emails, going to conferences, what you might think of as traditional dissemination strategies. What we did in the spring was piloted a structured social media strategy to try and gain traction and get traffic to our site. And so for an 8-week period, we had posted a blog on a different topic. So we would post the blog on the Monday of each week. This is one example, making medical procedures less painful for kids, reviewing the evidence around that. And then that went up on the Monday. Throughout the week, we had a structured Twitter feed. And so we would tweet about the blog 3 times a day for the rest of the week until the next blog went up the next week. So these are just examples of the tweets related to this blog. We'd include different handles, hashtags. I knew nothing about this before. I had to learn from the best, Terry Clausen, the social media expert. Oops, oh, I didn't know you. Okay, so yeah, so we did this for 8 weeks. Here are some of the results. So during the 2-month social media campaign, we had an 18% increase in Twitter followers. We had over 5,800 views of our 8 blog posts. We had over 39,600 total Twitter message views, and there are ways to track this information. Our information scientist does most of this for us. We also, what was interesting is that while our immediate audience is Canada, we did see traffic from a lot of other places. So the big places were US, France, and the UK that were visiting the TREC site. And then these are just general stats for the trec.ca website. So 1,200 visitors per month to trec.ca on average in 2015, and that was a big increase from 2014. Probably due to not only to the dissemination strategies, but also we just have more information on there. And the TREC author bottom line recommendations have been accessed 1,097 times, which is probably higher now. So we are continuing to run more of a streamlined social media dissemination strategy now. What we did learn in the social media strategy is that it can be very labor intensive and needs to be very intentional. Again, you need to know who your end user group is, what messages you want to send, and try to understand where are they going to, what are they looking at, and what are they interested in doing. What I didn't mention, well, I'll mention it here. So anyways, we're running a streamlined approach right now through to the end of the year, which coincides with the end of our funding period. Hopefully we'll be renewed and we can do this bigger and better and more intentionally. So again, we're posting a blog once a week. It's largely driven by a systematic review, including the plain language summary, and then we're tweeting about that blog as well. These bit.ly links tell us, take the viewer back to the blog, so we're able to see how that traffic is working, where the traffic is coming from. So that's kind of what we've done for our healthcare providers. So along the way, we've also been talking about developing knowledge tools for parents. And one thing we wanted to investigate, and have been investigating for a number of years now, is the use of storytelling as a vehicle to communicate health information to parents. And so we started this, driven by Terry, under Terry's leadership, over 10 years ago. Shannon and I, as trainees, naive, unsuspecting trainees, under his leadership, got involved in looking at this question of can we use narrative as a vehicle to transfer information to parents. And so our initial investigation of this was in the area of croup. We chose that because it was an area that Terry was interested in clinically, as well as there's a lot of strong evidence for the management of croup. And so we developed these 3 storybooks. They target a different severity of croup, so we want to have one on mild, moderate, severe. Initially, we had a creative writer go into the emergency department and interview parents of children with croup. She developed some stories, some prototypes. We kind of blended those, added in the evidence, and came up with a product. We involved an illustrator and a graphic designer and created some paper-based products. We then, and so we've had a number of publications around our storytelling work. So the top one is just about the development of these types of interventions and some of the challenges, the processes we followed, but some of the challenges that we encountered. We then ran a randomized controlled trial. It was a 3-site, 2 in Alberta and 1 in Ontario. We recruited just over 400 parents, and so half got the storybooks, half got a standard information sheet. Alongside that, Shannon led a qualitative component, so she interviewed a subset of the sample of parents who received the storybooks. So that's been written up, and then the results of a randomized controlled trial were published several years ago. So what we wanted to do within TREC, we'd done this work, but we also learned that parents look for information on the internet, and we had developed these hard copy books, and so we wanted to develop an ebook and put it in electronic form. And so we worked with a digital media company. So this is the landing page, talking a bit about croup, signs and symptoms of croup. What they can do is click onto this and hear the cough, that's a hallmark sign of croup. And then they can read the interactive storybook or click on a link for more information about croup. And so what they did was they took our 3 stories and put them into one and put it into electronic format. So this is just a sample page from the electronic book. And again, people can scroll over some of the features on the site and hear the audio recording, or there are pop-ups for additional information in terms of looking at what's going on, definition of croup, etc. Here the mother's talking to, she's phoned a HealthLink line, Alberta's HealthLink, Manitoba has their own, and the person at the other end is going through some of the questions that somebody might be asked if they're suggesting that their child might have croup. So this is informing the parent about what questions they might be asked or to look for these features in their child. And so we evaluated the ebook at 4 sites, 4 TREC sites, 2 in Alberta, 2 in Manitoba. We had 40 parents answer some questions. These were the items we looked at. They were asked to respond on a 5-point Likert scale from strongly disagree, disagree, neutral, agree, strongly agree. They all rated somewhere around 4.5, 4.6. So they all agreed or strongly agreed to these comments. in terms of the ebook provided useful content. They found it engaging. They found the information to be relevant for the parents. The format was easy to use. It met their expectations in terms of format, met their expectations in terms of organization of the material. They found the components functional. We wanted to make sure it worked. Addressed all of my information needs. They were satisfied with it. Parents would use ebooks like this one to find out health information, so they strongly agreed with that, and they agreed that it should be made publicly available. However, just fantastic, we're heading in the right direction, but they did have comments, and I think this is really, really helpful for us as we continue to create products for the parents. So one parent said, if my kid is sick, I want the info fast. I would not bother with the story, I just want the facts. However, if I were sitting in the ER waiting for something else, I might pick it up and read it because it's engaging. So it's two different messages there. They're finding this format engaging, so that helps us as we're developing other tools in the future. But they also want info fast, so they don't necessarily want to, leaf through or read in detail a long story. Parents with no family around, parents from different countries could benefit from this. Again, really useful information to us in terms of who our audience is. Also in terms of where parents are finding information. So it's kind of suggesting that people go to their families, right? Their networks, and so that's an interesting demographic in terms of who we might want to be targeting as well. I don't know if I would use this format if I was at home searching for info on croup. And then another comment that suggests who our demographic audience might be. For low income and newcomers, there needs to be more visual than text, or how we format that information. So I thought that was really telling our importance as we move forward.
So the show and tell is going to continue. I'm going to share with you a couple of different mediums that we're starting to use in addition to ebooks. So Lisa Nisley presented at the start about the fact that with Trek, we're currently undergoing renewal, and we should find out in the next few weeks, hopefully, in terms of if we've been renewed. And if we move to renewal, one of the three key areas we're going to be working on is continuing this whole arm of work in terms of empowering families to make informed pediatric healthcare decisions. So we didn't want to wait. We didn't want to wait for this renewal funding. We wanted to start to try out some of these ideas. So we received other funding from CIHR to start the development of some of these tools. And I just want to stress how we're working very hard to ensure that they are accessible on multiple devices and platforms such as desktop computers, iPads, iPhones, etc. in terms of that piece, and really tailoring to different languages, multiple cultural groups. So in addition to the croup ebook, we've also developed a croup whiteboard, and I'm going to show you a small clip of that. A gastroenteritis ebook, and I've got some screenshots I'll show you, and a whiteboard. So just a couple of weeks ago, we went to the Canadian Family Advisory Network, which is part of CAFC, the Canadian Association of Pediatric Health Centers. And this was our second annual meeting with the CFAN group, a parental group, and they are so excited about these tools. Parents cannot get enough of this. They are so excited to have the art and the story component along with the healthcare information. So essentially the way that we use this opportunity to engage parents is we show them prototypes and get feedback that we use to refine them before we go to broad scale testing. And we are going to be doing usability testing in spring 2016. Now I'm just going to show you the clip of the whiteboard. So this is just a short one of the croup, just to give you a sense. There it is.
You finally put your little one to sleep. It's been a long day, so you turn in early. But in the middle of the night, you hear coughing on a monitor, an almost barky cough, like there's a seal in the room, and the breathing sounds off. There's a high-pitched sound. There's a chance this might be croup. Croup symptoms can begin quite suddenly, usually late in the evening when your child is lying flat. You finally put your little one to sleep. It's been a long day, so you turn in early. But in the middle of...
So that just gives you a sense of how we're trying to merge the power of story and art together, as well as provide the audio with it. This is a very finicky mouse. There. So this was the backup line. I had screenshots of the whiteboard, just in case. And these are some screenshots of the gastroenteritis ebook that we're currently developing. And this is the stage that we're currently at with the development of this ebook. So we've got the story developed, we've taken this back to the parents. We've been working with an illustrator actually out of Brazil in terms of this. So we're really trying to shake up the different types of art as well as the cultural groups that we're highlighting in terms of that piece. I really want to stress the way that we're engaging families in the development. So it's not just a group of healthcare professionals sitting back, doing this, and then pushing it out. Families are really involved in this entire process. So we're going to try again. I'm going to show you the gastro board. So again, this is a prototype.
Chris is sick.
We really agonized how to demonstrate the moment.
Unfortunately, the pediatrician is out of the office for a few days, and we can't get in to see him until next week. Unsure about what to do next, I remembered a time when Chris was very young and he had so much diarrhea and vomited so much that we took him to the emergency department. It ended up that he was sick with a virus called gastroenteritis that caused him to become very dehydrated because more fluids were coming out of him than staying in his little body. I worried so much about him. Luckily, they gave us an information sheet about the virus and what to do in case it happens again. It certainly seems like he has gastroenteritis again. I'd better check to see if he is dehydrated. That was what made it so serious last time. Viral gastroenteritis. How can I tell if my child is dehydrated? Signs of dehydration include 1. Thirst. 2. No tears when crying. 3. Sunken eyes. 4. Dry mouth. 5. Infrequent peeing. 6. Cold hands and or feet. 7. Tiredness and or no energy. He doesn't seem to be dehydrated. He's just tired and upset because he wants to feel better. Should we take him to the emergency department? When should I bring my child to the emergency department? 1. Child is tired with no energy. 2. There are no tears when crying. 3. No pee for 16 hours. 4. Overall, more fluid coming out, vomiting and or diarrhea, than going in, drinking. 5. Constant stomach pain for 6 hours. 6. Blood and poop. Since he just seems to be tired without these other symptoms, I think we should first give him Tylenol for his fever and some Pedialyte so that he doesn't become dehydrated, and wait it out to see if he develops any of the symptoms. If he does, then we'll know to bring him to the emergency department. We might even try to give him some soup if he feels like eating. This video was brought to you by Echo, Arch, and Trek. It was funded by the Canadian Institutes of Health Research.
That's just a little snippet of where we're currently at. with the development of additional prototypes. We're working on a couple of other areas as well. So we have an asthma ebook that is currently just wrapped up in terms of development. It's a doctoral student that Lisa Hartling and myself are both co-supervising. And we're also currently working on an ebook for pediatric chronic pain. And this was an institutional request in Edmonton from the Stollery Children's Hospital Pediatric Chronic Pain Clinic. So in terms of that piece, we just finished the qualitative interviews with parents. So this just gives you a sense of what the asthma tool looks like. The writing style is quite different in this particular tool. It's a diary style written in first person. So just in terms of wrapping this all up, so we do have some time for questions, is that parental engagement is really fundamental and key. And as anybody knows that has tried to engage families in their work, that takes a lot of time and energy to keep families involved, as well as the fact that a lot of this work has been informed by the results of our needs assessment. So we really took to heart what families said to us and what healthcare professionals said to us in terms of developing these tools. And just stressing what Lisa mentioned, this sort of iterative nature in terms of we develop tools, we send it back out to the users, we do refinement in terms of that whole piece. And the other piece that we really haven't talked about is the whole idea, this whole stream of work of how we're constantly updating these tools as well, so that they do reflect the best available research evidence. And so with all of the tools we're developing, we are constantly searching the research evidence in terms of when do we need to make refinements to the tools. So an incredible amount of work to ensure that what we're sharing with families is up to date. So I'm not sure if there's any questions, but thank you very much.